Alright, so let's start digging into chapter 2 a little bit, and this is going to start on really on page 48 of your textbook. So there you go. And we are going to really start talking about the different types of joint classifications. There's three basic types. There are fibrous joints, so if you look at our teeth there or sutures within our brain, these are considered your fibrous joints, so they aren't necessarily joints that move a lot, but we'll go over some examples of these, but you can see they're highly secured by connective tissues there. There are your cartilaginous joints, so we'll go over this. So a lot of people think of the pubic symphysis as a cartilaginous joints. Your intervertebral discs are joining the vertebrae to create those joints, and then the connections to our rib and sternum and so forth. There's a lot of cartilage, fibrocartilage, and connective tissue connecting that. And then finally, we'll start talking about this. These are the joints that we focus most on in physical therapy interventions, the synovial joints. Sometimes you'll also see this referred to as diarthrodial, and we'll go over some of the characteristics of these synovial joints coming up here. So let's start with a little case study from the book. So this is page 50 of the 6th edition of the textbook. On the left-hand side, talks about Sion Tenelu is a 16-year-old football player who hyper-dorsiflexed his ankle. So what does that mean to hyper-dorsiflex his ankle? Well, that's going to mean bringing the toes back up towards the knees, so or in a superior or proximal direction, excessive dorsiflexion when he was tackled from behind. So here's a case. I'll let you read this a little bit more. So the joint that we're talking about is the syndesmotic joint between the fibula there and the tibia there. So that joint right there is the one that we're referring to. So this is a fibrous joint. There's fibrous connective tissue connecting that collagen that's connecting that joint together. Now, although the structure allows relatively small but important movements between the tibia and the fibula, the stability of this joint is critical because the bones together form the proximal segment of the synovial or diarthrodial talocrural joint. So down here, when we think of our ankles, we think of typically the talocrural joint, where the talus forms with the tibia and the fibula there, and your medial and lateral malleoli are right there. So if the distal aspect of this joint is disrupted, it's going to affect things throughout the kinematic chain. We know that any injury in the body can affect something proximal at the proximal joint, so this could have impacts at the tibiofemoral joint. It could also have distal impacts at the talocrural joint, and this is going to affect stability and other function and activity. Now, do you know what kind of ankle sprain this would be considered? Yes, so we are going to call this a high ankle sprain, or at least that's the layman's term. And if you watch sports, you hear, oh, someone had a high ankle sprain. But really, it's a syndesmotic sprain. It's a sprain of the connective tissue, the fibrous connective tissue during the tibia and the fibula. So it's a lower extremity syndesmotic sprain. We also have a syndesmosis, another part of the body. Could you imagine where a syndesmosis is very similar to the tibia and the fibula would be? Yes, so there you go, in the forearm between the radius and ulna. And what's interesting about that, because it's not typically weight bearing, we don't really injure that syndesmosis as much. So you've probably never heard of a high wrist sprain or anything like that, because it typically isn't injured. Other structures tend to fail or break when you put a lot of force through the forearm and through the hand. So there you go. So let's take some time looking through this picture and looking at what's known and what we focus on, synovial joint or diarthrodial joint. With the synovial joint, you probably guessed that there's definitely synovial fluid within here. So in this blue area, it's representing that synovial fluid. But what do you think's surrounding that synovial fluid? there's a synovial membrane. And so within the joint cavity, where the blue is represented, you're going to have that synovial fluid, which is this natural lubricant. It's almost thick like a syrup type material, and it does change with aging. We'll talk about that. But you have this basic oil, or this fluid, this synovial fluid within here, within the joint cavity. Now, between the femur and the tibia, you also notice that there's fibrocartilage, and so we know that structure is the meniscus. So there you have that structure within there, and you have a medial and lateral meniscus within right there. You can see that also there's some protection. There's a fat pad protecting that to protect any contusion. So if you were to land directly on your knee, it would cushion that blow. But in particular, let me see if I could point this structure out here. So if we look at the ends of the bones, what kind of cartilage is at the very end of the bone? It's not the meniscus. What is that structure? Yeah, so that's your articular cartilage, or some people call that the hyaline cartilage as well. Surrounding all of this, you actually have a fibrous joint capsule to keep all that in there. If there's any kind of swelling, the whole structure, the whole capsule can swell. And what kind of condition would be associated with a swelling or an inflammation of the capsule? You would have a capsulitis. And a capsulitis is characterized by a significant loss of range of motion because it's going to affect the whole synovial joint. So flexion and extension are going to be limited, and we'll talk about how there are some patterns where if the capsule is inflamed or irritated or aggravated or painful, which usually goes with this, what is the typical capsular pattern that's associated with this? Let me clear up the screen a little bit here. Okay. So what are some of the roles that the synovial fluid plays? We said that it was, and my picture's in the way a little bit here. Let me clear that out. So we know the synovial fluid has these two components, and in particular, there's hyaluronate, and that helps viscosity. When you think of viscosity, most people equate that to a syrup. So if I'm thinking about water, and if I'm pouring water over my pancakes, which why would I do that? That would have less viscosity than a nice thick Vermont maple syrup. That would have more viscosity. It's a thicker area. And so what about peanut butter? Well, peanut butter, especially if it's chunky, would have a high amount of viscosity, and we even say that's more of a solid as opposed to a liquid. So the hyaluronate provides that viscosity, and that there's more viscosity to it, it can actually help to decrease some of the friction there as well. So the other thing associated with that, the lubricant, that's also going to help with the lubrication. So those things are combined together naturally in our synovial fluid. And then you're probably aware that with aging, the synovial fluid changes. So if you think about what happens to us as we get older, things start to stiffen up. And so you can imagine if you had something in your joints, the synovial fluid in your joints there, and it became thicker and it had too much viscosity, it almost became like a solid material. It almost became like a really thick old peanut butter or something like that. It would actually not provide as much shock absorption as the oil or the fluid within there. So as we get older, the synovial fluid does two things. It starts to decrease in volume, so we lose synovial fluid. We know a component of synovial fluid is water, so as we get older, we lose water. And it also becomes thicker, or it has too much viscosity. So those are the two things that decrease the shock absorption and increase the irritation of these joints as we get older. Another thing to point out is we do have within our bodies this thixotropic effect. So unlike motor oil in our cars or something like that, the viscosity and the properties of the material are relatively static. But what's interesting about our bodies is that if you're sitting down for a long time, your synovial fluid actually starts to become more stagnant and starts to take on a little bit of a thicker role. And then as you start to do activity and movement, there's a change, a thixotropic change, in which our body adapts to the movement that we're performing, and it creates the fluid to be more adapted to the activity that we're doing. So it's kind of cool that our bodies are designed to change with movement or lack of movement. And this is why it's important to keep movement throughout our days and throughout our activities so that we can reduce the friction on our joints. Subsequently, patients, if they lose synovial fluid as they get in their 50s, 60s, and 70s, they can get synovial fluid injections. And there's Synvisc, which is a brand name for one of these, and other synovial fluid injections that the patients can get. I'll clean up the screen a little bit here, and we'll keep going here. So with this, several types of synovial joints. So you have uniaxial joints. So when you think uniaxial, you're probably thinking of a hinge joint. And what that means is it's going to move in one plane of movement. So at the humeral ulnar joint, it's moving primarily in which plane of movement? Yes, it's moving primarily in the sagittal plane of movement. What about the proximal radial ulnar joint? This is more of a spinning motion. It's pivoting. So as I take my hand, and if I rotate my hand, I'm doing pronation, supination. Which plane of movement do you think this would be? This is going to be your transverse plane of movement. So with this, we also have biaxial joints. And there's a lot of joints that are examples of this within the body, but bi for two, so it's going to move in two different planes of movements. At the thumb joint, or the first carpometacarpal joint, or CMC joint, as we sometimes refer to that, you'll notice that it's a little unique in that it's a saddle shape, which means there's a concavity and a convexity to each end. So if I look at a certain part of this, I'm going to see it's concave. If I look at another part of this, it's going to be convex. So depending on which direction the thumb is moving, it's going to determine whether it's a convex on a concave or a concave on a convex. So that's a little bit of a unique joint as well. And then you have triaxial joints. So there are some plane joints, which means that it's really not a good way in this example to say whether that's a concave on a convex or a convex on a concave. The joint surfaces are relatively similar to each other. And these joints, if there's a plane joint, you can imagine there's not generally much movement between plane joints. So the intercarpals are a good example of plane joints. Within the foot as well, at the midfoot, there's other plane joints. So if I'm looking at the cuboids or the cuneiforms, there's going to be some plane joints. Very little movement is going to occur between those. They're stabilized heavily by ligamentous structures, but there's still movement that we can manipulate and perform, and these bones can sometimes dislocate. So the lunate can commonly dislocate with a fall on an outstretched hand, rapid compression there. But most people think of triaxial as having 3 degrees of freedom. So when we think about our shoulders go in all planes of movement. Our hips go in all planes of movement. So a ball and socket is a good joint of a good example of a triaxial joint. Within the body, there's multiple tissues involved with this. So there's 4 primary types of tissues found within the body. Let me see if you could take some time to figure out what these are. So there's epithelial tissue, skin and lining other structures. What other types of tissues are found within the body? So did you have some guesses for what all those were? There's M, so there's muscular tissue. There's N for there's neural tissue or nervous system tissue, and there's C for connective tissue. And certainly connective tissue can occur within these other structures as well. So let's talk about connective tissues here. This is going to be an important one. So with connective tissues, you could see some of the different tissue locations for where this connective tissue occurs. And one of the things I'll draw attention to here are the different water contents. So you can see that bone is a very dense material. And so with dense structures and dense tissues, we have very little water content. Whereas blood would have a high water content, as we know. Cartilage can vary. You can see that's a big range, 60 to 85%. Well, it depends on the type of cartilage, the age of the cartilage. So the meniscus of a 25-year-old may have significantly more water in it, and maybe closer to 85%, than let's say the meniscus of a 65-year-old or 55-year-old. And certainly aging and activity, lifestyle choices, and other things like that can factor into this. Ligaments and tendons, and you can kind of see a representation. There are many different types of cartilage. You're probably going to hear about the different types of cartilage. There's three main types that we're going to focus on, and in particular type 1 and type 2, and the reorganization that happens between type 1 and type 2. Now, do you know which one is stronger or has a higher tensile stress? Which one, type 1 or type 2, could resist more forces and sustain more force elongation? Yes, so type 1 cartilage is generally going to be considered the stronger of the cartilages. Sometimes I relate this to NCAA sports. There's Division 1, which is generally considered to be stronger than Division 2 or Division 3. But if there's any athletes out there, I'll let you make that determination. But in terms of cartilage and collagen, type 1 collagen is generally stronger from a tensile strength standpoint than type 2. And we're trying to have our patients replace or remodel their type 2 cartilage by giving them stresses and remodel it into type 1 collagen production. And we're going to do that as physical therapists with stresses, mechanical stresses and loads. There also we'll talk about some nutritional and other health characteristics that may help you produce more collagen. So talking about collagen, what is collagen? It is a protein, and it's between 25 and 30% of all proteins in mammals. What would you say, going back to biology, is the basic building block of collagen or of proteins? And those would be our amino acids. We know that the most common types of collagen are 1, 2, and 3, and we know that type 1 is the strongest. And here are some examples of where collagen is throughout the body. But it's all over our bodies, and in particular we're trying to strengthen and load collagen in certain ways in physical therapy. Okay, this is just easy for me to remember because I'm a Steelers fan. So collagen does have a tensile strength similar to steel. Okay, so let me just... Alright, got that typed in there for you. So there you go. And then certainly an interesting trend over the past few years is they've been starting to place collagen in all types of food and supplements and all types of other things. The thought is if you ingest collagen, that may help the nutrition of the collagen in the body to help that promote growth and improvements there. It's not always the case. There are certainly important things to do from a nutritional standpoint, but ultimately if we don't mechanically load the tissue and give them forces that way in multiple directions, the ligaments, the cartilage, and other structures aren't going to strengthen. So if you take someone in bed and you feed them more collagen, they're not necessarily going to develop thicker or more tensile strength in their tendons and ligaments if they just don't do anything mechanical on top of that. So collagen's good to have, and you want appropriate nutrition, but you also have to mix that with the mechanical stress, which will improve the overall strength of the collagen. And then when we get to class, we'll start with this slide and we'll go to it from here. So I'll see you in class, and thanks for tuning in today.